first-generation sulfonylureas, glyburide, is metabolized in the liver into products with a very low hypoglycemic activity. Glyburide has a few adverse effects other than its potential for causing hypoglycemia. Flushing has rarely been reported after ethanol ingestion, and the compound slightly enhances free water clearance, is also contradicted in the presence of hepatic impairment and in patients. Glyphosate has the shortest half-life, which has 2 to 4 hours, of the more potent agent. For maximum effect in reducing postprandial hyperglycemia, this agent should be ingested 30 minutes before breakfast because absorption is delayed when the drug is taken with food. Glyphosate is approved for once daily use as monotherapy or in combination with insulin. It achieves blood glucose lowering with the lowest dosage of any sulfonylurea compound. The half-life under multi-dose conditions is 5 to 9 hours. It is completely metabolized by the liver to metabolites with weak or no activity. Glycoside has a half-life of 10 hours. It is completely metabolized by the liver to inactive metabolites. Meglitinide analogs. Repaglinide is the first member of metaglinide group of insulin secretagogues, has a fast onset of action with a peak concentration and peak effect within approximately 1 hour after ingestion. Duration of hours. It is cleared by hepatic CYP3A4 with a plasma half-life of 1 hour. Hypoglycemia is a risk of meal if the meal is delayed or skipped or contains inadequate carbohydrate. It can be used in patients with renal impairment and in the elderly. Metaglinide is a benzosunic acid derivative that binds to the sulfonylurea receptor and is similar to repaglinide in its clinical effects. Diphenylamine derivative is metaglinide. A diphenylamine derivative stimulates rapid and transient release of insulin from beta cells through closure of the ATP-sensitive K plus channel. It is absorbed 20 minutes after oral administration to peak concentration of less than 1 hour. It is metabolized in the liver by CYP2C9 and CYP3A4 with a half-life of about 1 hour. Hypoglycemia is the main adverse effect. It can be used in patients with renal impairment and in elderly. So biguanides, metformin, is the only biguanide currently available. The mechanism of action remains elusive, but their primary effect is to activate the enzyme AMP, activated protein kinase, AMPK, and reduce hepatic glucose production. Patients with type 2 diabetes have considerably less fasting hyperglycemia as well as lower postprandial hyperglycemia after administration of biguanides. However, hypoglycemia during biguanide therapy is rare. These agents are therefore more appropriately termed eugoglycemic agents. It has a half-life of 1.5 to 3 hours. Is not bound to plasma proteins. It is not metabolized and is excreted by the kidneys as the active compound. The drug may impair the hepatic metabolism of lactic acid. With renal insufficiency, the biguanide accumulates and thereby increases the risk of lactic acidosis, which appears to be dose-related complications. So the clinical use are recommended as first-line therapy for type 2 diabetics. Because metformin is an insulin-sparing agent and does not increase body weight or provoke hypoglycemia, it is offered obviously advantages over insulin or sulfonylureas in treating hyperglycemia in such persons. It is also indicated for use in combination with insulin secretagogues or thiazolidine in type 2 diabetic in whom oral monotherapy is inadequate. Metformin is useful in the prevention of type 2 diabetes. The toxicities is the most common toxic effects of metformin are gastrointestinal, like anorexia, nausea, vomiting, abdominal discomfort, and diarrhea, occurring in up to 20% of the patients. The dose are related tend to occur on onset of the therapy and are often transient. However, metformin may have to be discontinued in 3 to 5% of the patient because of persistent diarrhea. Lactic acidosis can sometimes occur with metformin therapy. So thiazolidinediones act to decrease insulin resistance. These are ligands of peroxisomes proliferator active receptor gamma or PPARF, a part of steroid and thyroid superfamily of nuclear receptors. PPAR receptors are found in muscle, fat, and liver. It modulates the expression of the genes involved in the lipid and glucose metabolism. Insulin signal transduction and adipocyte and the other tissues differentiation. Pioglitazone has some PPAR alpha as well as PPARY activity. Is absorbed within 2 hours of ingestion. Although food may delay uptake, total bioavailability is not affected. It is also metabolized by CYP2C8 and CYP3A4 to active metabolites. Rosiglitazone is rapidly absorbed and highly protein bound. It is metabolized in the liver to minimally active metabolites, predominantly by CYP2C8 and to a lesser extent by CYP2C9. Is approved for use in type 2 diabetes as monotherapy. Drugs mimic incretin effect or prolonged incretin action. Oral glucose load provokes a higher insulin response compared with an equivalent dose of glucose given intravenously cause a release of gut hormones or incretins, principally GLP-1 and glucose-dependent insulinotropic peptide or GIP that amplify the glucose-induced insulin secretion. GLP-1 effect is glucose-dependent and the insulin release more pronounced when glucose levels are elevated, but less so when glucose levels are normal. For this reason, GLP-1 has a lower risk for hypoglycemia than the sulfonylureas. The suppresses glucagon secretion, delays gastric emptying, and reduces apoptosis of human in culture.
This is Jana Marie Baksarpa. I'm going to continue the topic. I'm going to tackle about glucagon-like peptide 1 receptor agonist or GLP-1. Um, Glucagon-like peptide 1, it stimulates glucose-dependent insulin release from the pancreatic islets. It has also been shown to show gastric emptying. It inhibits inappropriate post-meal glucagon release, and it also reduces food intake. So, exenatide, a derivative of exendin 4 peptide and gala monster venom, has a 53% homology with native GLP-1 and a glycine substitution to reduce degradation by DPP-4. Major adverse effect is nausea, about 44% of the users, which is dose dependent and declines with time. Exenatide monotherapy and combination therapy results in HbA1c reductions of 0.02 to 1.2%. Liraglutide is a soluble fatty acid acetylated GLP-1 analog. Half-life is approximately 12 hours. Albiglutide. Human GLP-1 dimer fused to albumin, and it's an agonist drug for diabetes. The half-life of albiglutide is about 5 days, and a steady state is reached after 4 to 5 weeks of once weekly administration. Most frequent adverse effects were nausea and injection site erythema. So it was albiglutide. The popular brand name is Tanzium. It was discontinued last 2018, but there was no known safety concern. It was discontinued due to limited prescribing of the medication. Dulaglutide consists of two GLP-1 analog molecules covalently linked to an Fc fragment of human Ig4. The GLP-1 molecule has amino acid substitution that resists DPP-4 action. Half-life of dulaglutide is about 5 days. The most frequent adverse reactions were nausea, diarrhea, and vomiting. So dulaglutide is the newest addition to the GLP-1 receptor agonist family. It is more effective than other anti-diabetic agents by reducing the HbA1c or hemoglobin A1c, which is considered to be pre-diabetes. So it reduced HbA1c by close to or greater than 1%. So dipeptidyl peptidase 4 or DPP-4 inhibitors works by blocking the action of the DPP-4, an enzyme which destroys the hormone incretin. Incretin helps the body produce more insulin on when it is needed and reduce the amount of glucose being produced by the liver when it's not needed. So first is sitagliptin, is given orally as 100 milligram once daily, has an oral bioavailability of over 85%, achieve peak concentrations which 1 to 4 hours, and has a half-life of approximately 12 hours, primarily excreted in the urine in part by active tubular secretion of the drug. Common adverse effects include nasopharyngitis, upper respiratory infections, and headaches. Hypoglycemia can occur when the drug is combined with insulin, secretagogues, or insulin.